Well, very good morning to all of you, and good afternoon and good evening to all of those who are joining from rest part of the world. Today, our guest speaker for the day is Dr. Riya Balikar from Nagpur, and she's going to lecture us on Daratumumab-based treatment of newly diagnosed multiple myeloma. This webinar is brought to you by Mumbai Hematology Group, supported by Johnson & Johnson, Natco Oncology, Lucien Life Sciences, and Nirvin Life Sciences, and managed by Perfect Square. I thank Team Johnson & Johnson, Natco, Lucien, and Nirvin, Mr. Yash, Mr. Kalpesh, and the Team Perfect Square, Executive Committee of Mumbai Hematology Group. Our chief guest for the day, Dr. Karan Subramanian from Pune. Our guest speaker for the day, Dr. Riya Balikar from Nagpur. All our discussants who are themselves very eminent hematologists as well as hemato-oncologists, and you participants for spending a Sunday morning, afternoon, or evening from whichever part of the world you're logged in. Let me give a flavor of our next weekend activities. Next Saturday, that is 4th of May 2025 from 11:30 a.m. Indian Standard Time and 7 a.m. UK time, you're again Professor Dr. Andrew Davis from Southampton, UK, speaking to us on double and triple hit lymphoma, all you need to know in 2025. Let me introduce our discussants for the day, and they are displayed here in alphabetical order. I will stop for a while for you to have a look on all our discussants today. So these are our discussions for the day. Now it's time to introduce our guest speaker for the day. We have no other than Dr. Riya Balikar from Nagpur. Dr. Riya Balikar is MD, DM and DNB Hematology, consultant hematologist and hemato-oncologist, Blood and Heart Clinic, KIMS Kingsway Hospital, Wockhardt Hospital, Nagpur. She is Director, Hemo Heart Foundation, ex-honorary assistant professor at Indira Gandhi Medical College, Nagpur. Her core of areas of interest are sickle cell disease, ITP, lymphoma, and myeloma. She is also the principal investigator in multiple clinical trials. Today, she is with us and she is going to lecture us on Daratumumab-based treatment of newly diagnosed multiple myeloma. But before she does that, we have a special guest and chief guest for the day. We have with us Dr. Karan Subramanian from Pune. Let me introduce Dr. Karan Subramanian. Dr. Karan Subramanian is consultant hematologist at Sahyadri Specialty Hospital, Pune. It's my privilege to invite Dr. Karan Subramanian to inaugurate our webinar and give some words of wisdom. Well, thank you so much. I stop over here. Over to you, Dr. Karan. Sir, you're muted, sir. You're muted, sir.
Yeah.
Thank you.
Okay.
Please go ahead, sir.
Yeah. Good morning, everybody. On this beautiful, bright Sunday, I would say. So we have joined here to hear from Dr. Balikar about Daratumumab. What I would probably tell you is for all the hematologists or the young hematologists who are planning to do and going ahead, it is a fantastic time for all of us hematologists for being at this time, primarily because of the amount of progress that we are seeing in our specialty, right, in terms of the science and the understanding of the basic biology and everything. And I think even when I started, I did not know what a hematologist was, and I thought he was a person who would sit in the pathology lab. From there, the whole interesting point for me was to be able to see the slide of the patient, look at the RBCs, WBCs, and be able to get to some sort of diagnosis quite fast and be able to sort of contribute to the treatment in the right way. And that was very interesting for me. And from there, we have actually come on a long journey to imatinib and then rituximab and the monoclonals, and now furthermore. So I think for all of us hematologists, it is an exciting time to be a hematologist, to look at the RBCs and the cells and be able to diagnose the disease and also do some treatment. So I invite you all and ask Dr. Khurana to go ahead and start the lecture from Dr. Riya Balikar. Thank you.
Thank you, Dr. Karan sir, for that wonderful words of wisdom. And thank you for accepting as our chief guest for the day. Thanks a lot. Dr. Ria, screen is yours now. Please go ahead.
Sharing my screen. Is it visible?
Not yet. Now it's visible. You can put in full screen mode now. Yes.
So the topic that I've been given is DARA-based treatment of multiple myeloma, newly diagnosed. And like Dr. Kannan has said, we are a long way now into monoclonal antibodies. We've come up with newer molecules like CAR-T, bispecifics. So it's a very, very interesting time indeed for us hematologists. So regarding this topic, this we discussed under the following subheads: history and evolution of myeloma treatment. We'll just look at the guidelines in brief, a little bit about the molecule itself, treatment of transplant eligible, ND stands for newly diagnosed multiple myelomas, and transplant ineligible multiple myelomas. Special settings where we really need to go out of the way to treat the patient, the frail patient, the renal patient, and the ultra high-risk cytogenetics patient. Response evaluation in myeloma, MRD-guided treatment. DARA as a maintenance therapy, this is something that is coming up in a big way now. The challenges that we face with DARA and infection, and a little bit about subcutaneous DARA. So way back in 1842, the first case of myeloma was discovered by Dr. Solly. It was a homemaker, her name was Sarah Newberry. She presented with abdominal distension, fractures, and pain. And the treatment that was given at that time was opiates, orange peel. You can look at that, orange peel infusion, rhubarb pills, arrowroot, and that's it. We've come such a long way from that to what we are doing now. Next comes this, we've heard of the Ben-Jones protein. So this particular gentleman in this picture is Dr. Henry Ben-Jones, who discovered this in the urine of patients from multiple myeloma. And that was the basis for the diagnostic tests of multiple myeloma, the protein electrophoresis that we so commonly use. Now, on the right-hand side, you have a bone marrow of a patient with multiple myeloma. The left-hand side, the bone marrow is a normal marrow. So we know that multiple myeloma, this is just a brief insight into myeloma for the students who joined here. Multiple myeloma, as we know, is a clonal proliferation of malignant plasma cells in the bone marrow. It is characterized by the presence of a M protein, which is nothing but a monoclonal protein produced by the plasma cells, and associated organ dysfunction. Multiple myeloma, the cases when I was doing my DM and now, I've seen at least a 4 to 5-fold increase in the number of patients with multiple myeloma. These are the classical presenting features of multiple myeloma. They come to us with bony pains, the most common thing, presentation. They come to us with cytopenias, renal failure, both acute and chronic, infections, and sometimes neurological symptoms. So this is what a classical picture of myeloma would look like. We know about the CRAB criteria, which are the myeloma defining events. CRAB stands for calcium, renal involvement, anemia, and bony disease. The spectrum of myeloma, and now there's a lot of research happening into this also. Initially, we were just focusing on multiple myeloma, but now a lot of research, including the next generation sequencing findings in the pre-malignant stages of myeloma, which is MGUS, and smoldering multiple myeloma. Smoldering myeloma is nothing but myeloma which is not symptomatic, or rather which is not associated with any organ damage. So criteria for diagnosis, we saw that to label any cancer, you need a biopsy evidence of the cancer. So a bone marrow or a plasmacytoma, which is showing you plasma cells. Any one of the myeloma defining events, we saw that. And now there was a lot of research, like I said, into this particular subset of patients, the smoldering myeloma patients, who could later evolve into multiple myeloma. So the question there was, if this patient invariably is going to evolve into multiple myeloma over the next 2 years, why not treat the patient now? Why not prevent that complication from happening? So this particular subset of smoldering myelomas with something called the SLIM criteria. So plasma cells, which should be clonal, obviously, more than 60%. SFLC ratio of more than equal to 100 with the involved chains, they should be again more than 100, and more than one focal lesion detected by MRI studies. So this particular group of smoldering myeloma again goes into treatment. It's classified as myeloma. Coming to the staging, we first had the ISS staging, which just used the albumin and the beta-2 microglobulin. Then came the revised ISS, where the cytogenetics was also included. And now what we follow is the M-SMART classification for active myeloma. In this, high-risk myeloma are the myelomas with all these cytogenetic abnormalities, which are classified as poor risk. So mostly anything involving chromosome 14 other than 6 and 11 goes into high risk. So 414, 14, 16, 6, 14, 20, deletion 17p and TP53 we know is a very bad mutation to have, and gain of 1q goes as a high risk mutation. Now, what is interesting here is something called double hit myeloma and triple hit myeloma. In fact, 2024 was all about this. How differently should we treat double hit myelomas and triple hit myelomas? People propose something called a quadruple therapy. We'll be coming to that shortly to treat these myelomas, because these were the myelomas which had the worst prognosis and with the highest risk of progression. Now, this is the response criteria. We know that. We know what is VGPR. We know what is CR. We know what is stringent CR. Stringent CR is nothing but a complete response plus SFLC should have normalized and there should be no clonal cells in the bone marrow biopsy. So now we've come beyond this. The IMWG response criteria has now included MRD response criteria as part of its response criteria. So in that, we have 4 different types of MRDs. MRD we know can be done by flow cytometry or it can be done by sweep sequencing. So it is 10 raised to -5 is the sensitivity for both flow MRD, sequencing MRD. What is sustained MRD negative? Any patient who is MRD negative at 2 different time points, which are at least 12 months apart. That patient qualifies as a sustained MRD negative. And why this subgroup is important is because these patients have very good prognosis. Irrespective of the cytogenetics as baseline, if a patient has sustained MRD negative, that patient ends up doing very good in the long term. Now, this is very important when we look at the treatment also. So now, our aim should be to achieve a MRD negative status and rather a sustained MRD negative status. Mind you, the treatment, the guidelines, we do use MRD negative, but to, justify escalation or de-escalation of therapy, MRD has still not come into play. We are still not doing a MRD guided approach rather. But as we will see this shortly, the newer trials which are being developed are more and more focusing on this. So now coming to the myeloma treatment proper, we know that the patient is divided into transplant eligible and transplant ineligible. In transplant eligible patients, the treatment would consist of an induction, consolidation with the transplant, and maintenance. Very simple. And in transplant ineligible patients, the consolidation phase is omitted. So you just do an induction and a maintenance. And the maintenance therapy here is continuous therapy till death or progression. So the aim of bifurcating this therapy into 3 parts is basically to reduce the disease burden. So transplant eligible, how do you judge which patient is eligible for transplant and who is not? So normally anyone who's fit, less than 65 years of age, is eligible for a transplant, goes for a transplant. Sometimes we even take patients of around 70 and 75 also for a transplant, considering that the risk associated with autologous transplants is not much. The treatment of multiple myeloma was revolutionized by the discovery of this molecule, Velcade. And initially, it was just a chemo-based approach. But the moment all these immunomodulators came into play, we had the PIs, we had the IMiDs, the PFS, the overall survival, significantly improved. Some years back, the treatment of myeloma was a doublet therapy. You just had one PI or a IMiD to steroids, and that was it. Then it was found that triplets did much, much, much better. So then came the era of triplet therapy. And now we are moving on to something called quadruplet therapy. So these are the myeloma drugs approved since 2000. In 2002, Bortezomib was approved. And this full armamentarium of drugs from Len, Carfilzomib, Ixazomib, then came Daratumumab, which was approved in 2016-17. And now we have come to bispecifics and we have come to CAR T therapy. So you can see as time has evolved, treatments have evolved, and you can see addition of and combination of drugs, RBD, so triplet therapy here. You can see the overall response rate, the VGPR rate has so much improved. This box here is showing us Dara. So addition of Dara across all groups, you can see the ORR has significantly improved. So Dara, which was initially used as part of second and third line therapy, is now entered into first line therapy. Now, a very sad thing about myeloma is for most of the patients, there is no cure. So myeloma is unfortunately a cancer that is going to keep coming back again. So there'll be a treatment-free, there would be a disease-free period, and then the patient relapses. And as you can see here, as the number of relapses increases, the response duration also increases. So the best response that you get is to your first line therapy. Also, the attrition rates, attrition refers to the percentage of the patients that would stick to your therapy or that would be lost to follow-up. So as you can see in the first line therapy, 95% of your patients are into treatment. But as this changes, as you go towards the fourth line, it comes to as low as 15%. And fifth line, it is just a dismal 1%. So why am I showing this figure? The only reason being is that at your first chance is your best chance. So when the patient presents to you, that is when I feel you should just hit the disease hard with whatever you have, whatever best you have to offer, rather than reserving it for the relapses. So there comes the role of this molecule that we will be discussing today, Daratumumab. So the first successful results that were published was this serious study that was published in 2016, where Dara was used as a monotherapy in heavily pre-treated refractory patients. And they found excellent results with this molecule. So Dara was instantly approved. And not just that, Dara came to be used as part of the frontline protocol for myeloma. So if you look at the latest update, till last year, we were saying, even I remember I presented something last year when I said that a quadruplet therapy, that is 4 drugs, should be reserved for patients with ultra high risk cytogenetics. But come 2025, this has changed. So the preferred regimen for all patients, be it transplant eligible or not, would be a quadruplet therapy. So if you look at the latest guidelines, you look at the latest updates by stalwarts like Dr. Vincent, Dr. Shaji, this is what they have to say. The other drugs, the triplet therapy is put in other recommended regimens. One more thing that has come up in a big way over the last 2 years is role of maintenance therapy. So the preferred regimen till now is still lenalidomide, but Dara is coming again in a big way as far as maintenance therapies is concerned, especially the combination of Dara and lenalidomide. So slowly, from a single drug maintenance therapy, we are heading towards a double or even a triple drug maintenance therapy. So this is the guidelines summarized in brief. Transplant eligible and not eligible. Not eligible, you can still opt for a triple therapy, though a quadruplet would be still better. Coming to the molecule proper. So this is for the students. Dara is a anti-CD38 targeting monoclonal antibody. CD38 is highly expressed in myeloma cells, and Dara is a IgG kappa mAb which selectively binds to the MAP38 containing cells. So directly it has an anti-myeloma effect by complement-dependent cytotoxicity, antibody-dependent cytotoxicity, antibody-dependent cellular phagocytosis, and apoptosis. It also has indirect effects. What it does is it increases the cytotoxic and the helper cells, the CD4 plus and the CD8 cells. And these cells again go and attack the myeloma cell. So it's an excellent drug which has selected action on the myeloma cells. I'll be discussing over the next 10 to 15 minutes about the important trials because every trial has a take-home message. So these are the trials which are, and I focused only on the trials for Dara upfront. So this is how they are divided. Some of them are for transplant eligible and some of them are for transplant ineligible patients. So Dara now is used, as we saw, across all myelomas, even amyloidosis. Now Dara is come into the frontline therapy. So all newly diagnosed, all relapsed refractory patients, monotherapy, combination therapy, Dara has been approved. This is again for the students about the dose of Dara, 16 milligram per kilogram administered as a IV infusion. It's given really slow over 6 to 8 hours. It's available in two sizes. One is 100 mg and one is a 400 mg. So typically our patients normally need around 800 to 1000. Some may go up to around 1200 milligrams. So we saw the dose, and the dosing is weekly for the first 8 weeks. After that, from week 9 to 24. So the next 8 weeks, you're giving once every 2 weeks. And then the recommendation is once every 4 weeks till progression. So this becomes a little financially non-viable for especially a country like India, where the cost becomes a big hindrance in ensuring optimal therapy. Now, what is the side effects that we see with Dara? The most common is the infusion-related reactions. Patient normally, especially with the first infusion, they present with chills, headache, and sometimes, rarely, a little bit of maybe hypotension. This is rare. The other common side effects are fatigue, nausea, diarrhea, pyrexia, cough. And as far as we are concerned, especially in the long term, neutropenia, lymphopenia, anemia, and propensity towards infections is important side effects. In fact, most of the serious adverse effects that were seen, especially grade 3, grade 4, they were because of infections, mainly pneumonias. So let's look at the clinical trials. I'll just briefly go through this. The Maya trial. So in the Maya trial, they basically studied Dara plus Lendexa versus Lendexa. The patients that were studied were transplant ineligible patients. dose of Dara we've already seen. So they gave an induction, and then the response here that was evaluated was the progression-free survival. So they followed the patient up for around 28 months. At 28 months, obviously, the PFS in the Dara arm was not reached, whereas in the Lendexa arm, it was 31.9. So you can see there's a big difference here in the Lendexa arm and the Dara arm. As you go towards 40 months, 42 months, this difference is even more apparent. You can see this graph here and this graph here. So you can see that the patients who are in the Dara arm, the triplet arm, have fared much, much, much better than the patients who just received Len and Dexa. And this benefit was seen across all groups. One bad thing, it was a very initial or early trial. So one bad thing or drawback of the trial was that they showed us that high-risk cytogenetics also benefited. If you go further on, they did show you that they did MRD, do MRD negative status, but it was not matched for the confounding factors. So they couldn't really compare. They've given us data. So the primary endpoint was just to look at the progression-free survival, because when this trial was introduced, they did not even know if Dara would be doing good or no. So later on, they've analyzed MRD, they've analyzed the risk-wise response, but they cannot comment on it because they've not confounded for the different factors. So you see at 64 months, the PFS benefit with Dara is still there. It's excellent. MRD negative, sustained MRD negative, again, they've shown, and the overall response, they've shown that Dara versus RD, DRD is much, much better. But like I said, conclusions cannot be drawn from this study. Overall survival, you can see, so much better. At 73 months, OS has not been reached in the Dara arm. That's excellent results. Across different subgroups, results maintained. Now coming to this important point, safety. So the most important adverse effects that they saw was infection, especially pneumonia. But if you look at the rate of treatment discontinuation because of adverse effects, it is still lesser in the Dara arm versus the Lendexa arm. So this was the author's conclusion, because the primary endpoint was PFS. They found that PFS benefit stayed for as long as 74 months post-treatment, and they did not have any significant safety concerns. Then around the similar time, this was the trial that they again started. It was the Alcyone trial, where they used a rather, I would say, they've used melphalan here, so I would rather call it a slightly primitive therapy. Because again, this was way back, I think in 2015 or 16 when they, came up with this trial. So Dara VMP versus VMP alone, and obviously Dara VMP scored much better than VMP alone. But if you compare this with the Maya trial, again, you see that Dara Lendexa is much better than the Dara VMP combination. So inter-trial, if you try to compare, risk of death was reduced. MRD negative, again, they've not really commented on this because that was not the end point in the treatment population. You can see the patients who were on Dara VMP arm and who achieved MRD negativity have done significantly better than the other patients. So now these were the two important trials for transplant ineligible patients. So we have two trials here for the transplant eligible patient. The first trial was the Griffin trial. This is one trial that everyone keeps talking about. So, and this is something that it's spoken about so much because this is the protocol that we normally follow in our practice. Induction, what they did was induction. A 4-cycle induction was done with Dara RVD. The dose of Len that they're using is 25 milligrams, and they've used it just for 14 days here. Versus the control arm was RVD alone. After 4 cycles, they've transplanted the patient. Then they have given 2 more cycles in consolidation of Dara-RVD. So consolidation includes a transplant plus 2 more cycles of Dara-RVD. And then they've gone for a maintenance. Maintenance from cycle 7 to 32, that's roughly 2 years of maintenance therapy. Dara and Len, doublet maintenance versus Len maintenance alone. So this is what they've done here. And the primary endpoint in the first trials, we saw it was just a PFS. So now slowly the endpoints are shifting. So the endpoint here is stringent CR. And the secondary endpoint here is the MRD negativity. So again, this tells us that as the trials have improved, as the trials have, the newer trials have come up, the response has shifted from just a PFS and OR to stringent CR, and slowly we are going towards a MRD negative status. So you can see this dark blue that shows you the stringent CR, the lighter blue below that is the CR. So you can see end of induction, this is with the Dara arm, the blue blocks that you can see. With the Dara arm, you can see the stringent CR rates and the CR rates are so much higher. In fact, more than equal to CR, that is your stringent CR, the rates are 67. And 67 is a huge number, end of study, that is end of maintenance. If you're getting a stringent CR of 67%, that is really good. Versus in the RVD arm, it is just 48%. MRD negativity now. You can see the rate of MRD negative is almost double. So in the Dara arm, 64% of the patients have gone MRD negative, whereas in the Len arm, RVD arm rather, it is just 30%. So Dara increases the rate of MRD negativity by around 50%, and that's a really big number. Progression-free survival, of course, there was a benefit which stayed. Overall survival at 49.6 months, overall survival was not reached. This data, they've said it is not mature enough for analysis purpose. The next trial in transplant eligible patients was the Perseus trial. The same thing again. They've used the same combination, but they've used Len for 21 days. Okay. Followed by consolidation and maintenance therapy. Here, what they've done is they've used a MRD guided approach. In the Griffin trial, it was just 2 years of maintenance and we were done. But in the Perseus trial, what they've done is they have used, in the Dara arm, they've used a MRD guided approach to guide your maintenance therapy. So if this patient is MRD negative, they have stopped the Dara therapy and they've just continued Len till progression. So they've continued drugs till progression, but MRD negative patients, they have discontinued Dara. But in patients who are MRD positive, they have continued Dara and Len both. So this is the difference. So we are looking at going towards a MRD guided approach as we are going towards the next line of trials. So you can see Dara RVD, of course, the PFS was much better as expected. And this benefit was seen across all high-risk groups also. So irrespective of your cytogenetics, irrespective of your ISS staging and performance status, the PFS benefit stayed. Overall response rates, again, expected to be good. It is good. MRD negative, again, you can see 47% versus 75%. As the time goes, as you're going towards maintenance, the rate is almost tripling here. So sustained MRD negative is, like we discussed, MRD negative at 2 time intervals, at least 12 months apart. You can see Dara really scores high here. It is 64% versus 29% in the patients who've not got Dara. Serious side effects, like we discussed, it is expected to be pneumonia, and it was pneumonia. One more thing that they found was the incidence of secondary primary malignancies. That is again pretty high. It is around 10% in the Dara VRD arm, and it is 7% in the RVD arm. So this could be because of Len. Len, we know, does increase the tendency towards malignancy. It could also be because of the transplant. Transplant, again, the risk of second malignancy is higher. Now, this is one important slide that I liked regarding the stem cell collection and the transplant. So, does DARA affect the stem cell dose? Yes. We can see in the VRD arm, the medium CD34 cells that were collected was 7.4. And the DARA VRD arm, it has come down to 5.5. So as per this trial and a couple of trials that were studied later, DARA did affect the number of viable stem cells collected. But did it have any effect on the transplant or the result or the hematopoietic reconstitution? The answer is no. In fact, the patients have fared as well as patients with RVD therapy, and the time for engraftment has also stayed the same. So we can conclude here from this study and a couple of more that DARA does reduce the stem cell dose that we get, but it doesn't affect the quality of the transplants in any way. So this was the conclusion. We've discussed it. So two things from this trial. One was regarding the stem cells and transplant. And the second was a MRD guided approach towards maintenance. And not yet applicable, but I think slowly we are going to that phase. In the next couple of years, I think MRD is going to come in a big way as far as myeloma is concerned. So next, DARA is all about trials. So just bear with me a couple of more trials and then we finish with the trial. So this was the LIDA trial. Same thing again. They've used DARA and Cyborg or VCD. So they've used cyclophosphamide, bortezomib, and DEXA. They've done a transplant. They've given maintenance for 12 cycles here, and they have stopped it there. So limited or finite maintenance. And DARA Cyborg is something which we do use in some subsets of patients. So again, similar results. They found that with transplant, without transplant, these patients did good. Overall response rate was good. Safety profile was very tolerable. So they've used a finite maintenance of just 1 year now. Now, this is a trial that everyone talks about, and that's the Cassiopeia trial. Cassiopeia was DARA. It had 2 arms. And again, a lot of things from this Cassiopeia trial. The first thing was the mode of study. It was DARA VTD versus VT. Did the same thing again, induction, transplant, consolidation. In the first arm, they've not used maintenance therapy. And the primary endpoint was stringent CR. Secondary, again, is MRD negative status. You can see response with time. Obviously, DARA fares good. MRD. Now, MRD negativity, again, they've done by 2 methods here. That's why this trial is important. They did it by flow cytometry, and they've also done it by NGS. And they found concordance between the two. Safety information, the same thing. Stem cell collection, again, the same thing. DARA, the stem cells, the percentage is lower, but the transplant result, you can see 100% reconstitution. So the same thing again. And this trial was important for 2-3 reasons again. Risk factor, cytogenetics, ISS staging, they've compared and they've done a genuine proper comparison, and they found that DARA scored across all arms. Post-consolidation depth of response in high-risk patients was remarkable. MRD by flow, again, across all groups, it was excellent. MRD negativity, here, this is what I was talking about. So they have compared MRD with NGS and with flow, and they found a little bit of a difference, NGS and this, there was around a 7 to 10% difference, but it was not statistically significant. So what they found is, irrespective of whether you do the MRD by the NGS or the flow cytometry, there is concordance between the two. So you can use either, because NGS MRD is something that is not available to us. You can see the observed agreement between the NGS and the flow MRD is around 85 to 90%, which is very good, which is pretty good for us. Now coming to the part 2, and this is something that is important for us. They've used Dara monotherapy. In the comparator arm, they've not used anything because when they started this trial, phase 2 of the Cassiopeia, there was no concept of something called a maintenance therapy. So in the comparator arm, there is nothing. This is unfortunate, but this is what they've done. And in the other arm, there is Dara monotherapy. And they've given it for 2 years. So finite therapy of 2-year duration. What did they find? They find that the progression-free survival in these patients who've been on Dara maintenance has not been reached till the last point of analysis. But in the Len arm, it's 46 months. You can see by induction, consolidation, maintenance, Dara scores over everything. Depth of response again, MRD negativity again. So they said that the Dara maintenance therapy, monotherapy, they concluded this, that it was much superior than not giving anything alone. But now we need more data. We need Dara maintenance versus Len maintenance. We need Dara plus Len as part of maintenance. So there are these 2 studies coming up, phase 2 Griffin. There is the Perseus study and the Auriga study. Not going into details of this. That's going to tell us about Dara plus Len maintenance versus Len maintenance alone. So these are the 2 studies. These are ongoing studies. Recruitment is still happening for these studies. So that was about all the studies. Now, special situations. So we discussed about the normal myelomas. What are the difficulties that we encounter when we treat myeloma? So the first thing is renal impairment. Around 50% of our patients almost would come to us with some sort of renal impairment. And in renal impairment, you need to act fast. Because if you don't act fast, if you don't treat the patient adequately, then the patients would all probability either end up with a chronic kidney disease or end up with some very high mortality rates. So it's very important that you treat these patients very effectively at the first chance. Len, as we know, is avoided in these patients. Even if you want to use it, the dose of lenalidomide would be really reduced. So the need for alternate therapy. So there is this subgroup analysis. There is no trial as such which has focused only on renal patients, but this is a subgroup analysis from one of the trials which said that, which compared these patients with renal involvement, and they found out that Dara with Lendexa significantly improved PFS, OS, and the risk of death by 45%. And that is a huge data. So Dara, again, is safe in any patient with renal disease. No dose adjustment is required. And Dara with RD scores well. And I would say that would be the treatment of choice in our patients who are renally impaired. So this is the key takeaway from this study. And the side effect profile was also the same. So that was the first subset of patients. The second category of patients is the frail patients. Again, as we know, myeloma is more a disease of the elderly. My oldest myeloma patient is 94 and she has CA breast and she also has myeloma. So this category of patients becomes exceedingly difficult to treat this particular subgroup of patients. So these are the different, how you assess frailty. It is not just the age, but it is the comorbidities, it is the fitness level that, puts the patient as a frail patient. So approximately 30% of our patients would be classified as frail. There are a lot of scoring indices regarding this. And IMWG itself has come up with a frailty score. So they classified these patients as frail, fairly frail, intermediate fit, and fit. So patients who are frail, overall survival in these patients with the previous therapies, if you just used PI or IMID, it was not so good. But then when you add Daratumumab to this, the survival goes up. The progression-free survival, the overall survival, everything goes up. So in these patients now, NSMART of study, just the recommendation here, for frail patients, the treatment of choice would be DRD, or you could do something called a DRD light, where you've really given low doses of dexamethasone, because in frail patients, dexamethasone, the lower dose that you can use, the better. So again, Dara is a very good drug in frail patients, also gives us a very good survival benefit and PFS benefit. Quality of life also in Dara, like I said, the 94-year-old that I have, I'm giving her Dara and she's on Dara maintenance now and she's doing excellent. Prior to this, her quality of life was really very bad, pains everywhere, weakness, but she's able to do everything now. It's found that Dara improves the quality of life also in these patients, which is such an important factor. So this is the treatment algorithm. So lower doses, in fact, in frail patients who are more than 75, Len dose that is recommended is 10. Dexa is just a 10 mg weekly dose. Even the bortezomib dose they've cut down on, they've got it to 1 mg per meter square. So this is something which is very important for us when we are treating these patients. Now, what about the high-risk cytogenetics? We saw that all the studies, there was a sub-analysis, especially the Griffin trial and the Cassiopeia, which told us that Dara does excellent when combined with RVD in patients with very high-risk cytogenetics. So this is what has been summarized here. Cytogenetics, adverse risk, Dara sometimes even nullifies the effect of the bad risk cytogenetics. The same thing here. So if you treated your patient with Dara and a quadruplet therapy with a high-risk cytogenetics, the patient has become MRD negative, then the baseline, you can see these are the patients with high-risk cytogenetics and these are the patients with good cytogenetics. So you can see that MRD negative is somewhat offsetting that effect of poor risk cytogenetics. So it can be used as a surrogate marker. Little bit about Dara subcut, the Darzalex Fast Pro, which has now last few months we are using it. So it is a subcutaneous injection. It comes along with hyaluronidase, 30,000 units of that. It's a flat dose. Unlike Dara, where the dose was 16 mg per kg, this is a 1800 mg flat dose. Responses are the same as IV Dara, no difference at all. Pharmacokinetics is good. Safety profile is much, much better. Now, why the need for the subcutaneous Dara? Why? Because for IV, every time the patient had to come to your hospital, subcut, the patient doesn't need any IV access. The patient can use it locally also, though our patients don't prefer to do that. A fixed dose again. Now, in patients who are volume overloaded, or giving a 500 ml or a 1 liter dose extra volume every week becomes difficult. Here it is just 15 ml. And people who are time pressed, every week you're calling them for 6 to 7 hours, precious time. So here it is just a 5-minute injection. And again, the infusion-related side effects that were there, infusion-related reactions with IV Dara were sometimes difficult to manage. So here it becomes very good. So safety profile is better and overall the patients are happier with this drug. So it comes with this hyaluronidase, and the hyaluronidase, what it does, it disperses the molecule. It sort of makes the Dara, because you're using 15 ml and you are injecting it in the same site. So it allows the drug to disperse because it causes some cellular reaction in the subcutaneous space and it causes the drug to disperse and get absorbed easily. Just given in 3 to 5 minutes. And these are the drug trials. We're not discussing this in detail. The Pleiades trial and Apollo trial, Columba trial, and the Andromeda trial. So pre-medications, when you're giving that, you need to give injectable Solumedrol, 125 mg for the first and second dose. Later, you can even shift to a oral tablet. Paracetamol and some injectable antihistaminic, like we do with our injectable Dara. Wait for 1 to 2 hours and then give the injection. This is how it is administered, subcutaneous, within 3 to 5 minutes. Trials, they just compared the subcut arm with the IV arm and they found that the PFS, the OR, the stringent SR, everything was the same. And the adverse effects were cut down by almost 50%. So this was the Columba trial. It was in relapsed refractory patients, but this is the landmark trial as far as Dara subcut is concerned. And the patients were very much satisfied. You can see this is a patient satisfaction questionnaire. You can see with the Dara subcutaneous arm, the patients are always smiling and happy. And with the Dara IV arm, most of the times they are not happy. They're frowning because they have to come to the hospital every week. So it is equally efficacious. It is safer, convenient, simplicity of the dose, and patients are much, much more happy. This we've seen. Coming to the last point of our discussion, DARA and infection. As is the case with all monoclonal antibodies, DARA also predisposes the body to infection, especially because it causes a lot of lymphopenia, neutropenia, and hypogammaglobulinemia. So it is very important to vaccinate your patient properly. It is very, very important to watch actively for infections. And this is the FDA has this particular site where all the drug adverse events are mentioned. So there was a particular paper that across all groups they found out, they put these keywords and they found out the incidence of these infections, herpes zoster, CMV, PML, PJP. This is nothing but pneumocystis, aspergillosis, hepatitis B reactivation, TB reactivation. And they found that with the DARA arm, the incidence was much, much, much more higher. And it was even higher. This is not very visible, but this basically tells us that in heavily pre-treated patients with a DARA combination therapy, the incidence of these infections is much, much, much higher than in patients who are newly diagnosed. So how to avert this? By vaccinating our patients, watching actively for infections, and using IVIG as and when needed. So the road ahead, we've spoken in detail about DARA. So the road ahead, we have a lot of other things coming up, which are already approved. We have Elotuzumab, which is against the SLAMF7 receptor. We have the Isatuximab, which is again a CD38 derivative of DARA. We have other CD38 monoclonal antibodies, which are coming up. Teclistamab is already available to us. These are talquetamab is going to be available to us. So these are the bispecifics antibodies. We have the CAR-T, which in India has come up in a big way. So the road ahead for myeloma looks really exciting with all these molecules coming up. And we hope for better and better survival for these patients. So to conclude, we discussed the guidelines. We saw that in 2025, what has changed is from triplet, we've moved on to a quadruplet therapy for both transplant eligible and transplant non-eligible patients, ineligible patients. The rationale being that the better you treat the patient, the more years that you give the patient upfront, the better would be the overall survival. We looked at the special settings, the frail patient, the renal patient, and the ultra-high-risk cytogenetics patient. We looked at the response evaluation. We've seen how all the trials are more and more going towards the MRD-guided approach to guide therapy. We've not yet reached this as far as our clinical practice goes, but over the next 2 years, maybe we would be looking at that. DARA's maintenance therapy is something that is going to be coming in a big way. We've already started using it in our practice in some groups of patients. We saw the challenges faced with DARA, especially infections, and we saw how some of these challenges can be mitigated by using subcutaneous DARA. So that was it from my side. Thank you so much, and thank you for your patient hearing.
Thank you, Dr. Ria, for the wonderful presentation. I think you touched every single aspect of DARA. Maybe infections, renal failure, all the points were beautifully covered by you. Fantastic. Thank you so much.
Thank you.
And I now request all our discussants to please put the hand raise signs so that we can start our questions with Dr. Ria. Dr. Dipti, your question, please.
Hi, Dr. Amit, myself Dr. Deepthi.
Yeah, please go.
From HVJC Kotak, Odisha. I want to ask Dr. Ria, what is the opinion regarding, because in transplant ineligible patients, what should be the duration of DARA? Because Maya and Alcyone we are seeing there is the long-term use of DARA. What is your practical opinion in a economic constrained country like India? What should be the induction, consolidation, and maintenance? What is your opinion regarding that?
Transplant ineligible patients, Tama? Transplant ineligible.
Yeah.
Yes,
Transplant ineligible.
Yeah. So ideal recommendation says you give your induction therapy for 8 to 12 cycles, 8 to 10 cycles or 12 cycles, and then you move on to your maintenance therapy. But in our country, it is not feasible. It is not feasible mainly because of the financial part of it, because Dara is a very expensive drug. So what I normally do is I give weekly Dara if I'm looking at Dara. If Dara is not an option, obviously it is RVD. I do 8 to 10 cycles of RVD, and then I put the patient on indefinite maintenance therapy for till progression or death. But if I'm using Dara, I give it weekly for the first 8 weeks. Then I will give it once every 2 weeks for the next 4 weeks. Recommendations say 8 weeks, but most of our patients do not do it till then. Plus the Janssen, the patient support program, they give it to you only for the first 12 doses. So after the first 8 weekly doses, I do it once every 2 weeks for the next 4 doses. And then I omit Dara. I use just the RVD. So I start with a quadruplet. I start with Dara plus RVD. After 12 doses, if the patient is willing, obviously I would continue it. Like they said, give it once every 14 days for 8 doses and then give it monthly. So if my patients are affording and willing, 3 of my patients they are taking it, but the other patients cannot afford it. So I try to give them a minimum of 12 doses and then put the patient on only RVD for 8 to 10 cycles, and then depending on what the cytogenetics was, a double or a single drug maintenance therapy.
Yeah, my second question to you again, regarding the MRT negativity approach, what we discussed in Cassiopeia or master trial, we have seen that is MRT negativity approach to give Dara. But if it is more than 2 high-risk cytogenetic abnormality, even though patient is having MRT negativity, there is a risk of relapse.
Yes.
Do you think that it is better to go for in those subset of patients, Daratumumab, or you do not want to give in that subset of patients?
In high-risk patients, I would give at least a doublet therapy in maintenance therapy. I would not stop if the patient is MRD negative, because right now we have the Cassiopeia trial that we saw and the master trial. So it is not guided as per the cytogenetic risk. It is generalized. They have not compared them. We have not yet come to that. Maybe in the Perseus and the other trials, which are Auriga trial, which are happening, Cepheus, Perseus, I think they would be addressing those questions. But as of now, MRD guided approach should not be used to guide clinical decision. In ultra high risk cytogenetics, which is our double and triple hit myelomas, double maintenance therapy with Dara and Len would be the treatment of choice. And continue it indefinitely is what I would recommend. Unless you've transplanted your patients, where you would give it for a finite 2-year duration.
Thank you, Ria, for your nice presentation. Thank you so much.
Thank you, ma'am.
Thank you, Dr. Dipti. Dr. Rama, your question, please.
Thank you. Thank you, ma'am, for your wonderful talk. I am just curious to listen from you. What is the treatment you give with the syndromic plasma cell dyscrasias like POEM syndrome, TEMPI and all? We still see the monoclonal plasma cells, even though they are less. Do you treat these patients with any specific drug, or is there any, or you do just wait and watch? Because 5% plasma cells. What is your approach in these syndromic patients?
You mean POEM syndrome patients, na?
Yeah, POEMs, TEMPI, ESOP recently,
Yes.
which are added. How do you treat them? Do you consider these monoclonal plasma cells, though they are less in number? Do you start the treatment, or do you keep them in wait and watch until they develop into full-blown myeloma?
Yeah. So regarding POEM syndrome is something that you cannot really wait and watch. I had a patient who was not diagnosed, unfortunately, for around 4-5 years outside. He just presented with, some neuropathy and Castleman's disease. And then this patient really evolved over time till the point that he became bedridden. So POEM syndrome is something that you should treat aggressively. It is what we see, what the textbooks mention and what we see, it's poles apart. So if the patient has POEM syndrome, the patient is clinically deteriorating, you should treat this patient aggressively. In fact, there is some data with DARA and Lendexa. Bortezomib is something you would choose to avoid in this patient because the patient has a neuropathy existing. So there is some data in POEMs with DARA and RD also. So in these patients who are symptomatic, you should treat them. But in the patients who are not, like the newer, lot of things have been added recently. So in these particular subsets of patients, there is a subset that you would prefer to just wait and watch, monitor, see how these patients would evolve. Not all of these patients need treatment, but if you would rather do a close follow-up, maybe once every 3 months, you would just monitor them for progression, and then only you would treat. So you need to decide which patients to treat and which patients not to treat.
Okay, so after monitoring for 3 months, which patients you're going to treat, ma'am? Can you just clarify? Like, how do you decide to treat, select the patients?
I would just take this example of POEM syndrome. So if the patient is, say, the neuropathy is worsening, the M band is increasing. If a patient just has maybe just a borderline Castleman's disease, you found that the M band is, see, honestly, there are no guidelines as such for these patients. I can understand that. But if the M band is increasing, if the plasma cells are increasing in the marrow, your SFLC again would play a role in this. Your renal dysfunction is increasing. Then this set of patients I would treat.
Okay, thank you, ma'am. And Tempi also similar or similar lines of
Similar
thoughts?
sort of approach for that also.
Okay, thank you so much, ma'am.
Yeah.
Thank you, Dr. Rama. I'll just like to add on with this POEM syndrome. I had a talk with Dr. Ashutosh Vanslekar once during our MHG meet. And what he said to me was the number of plasma cells doesn't matter over here. It can be just 3% or 2% or 4% plasma cells that is creating havoc in POEM syndrome. It's not like myeloma where you have 15%, 20, 30, 40% plasma cells. So just 2 to 3% plasma cells is fair enough, and you must eradicate that plasma cells clone. And these are the patients you must transplant that patient immediately. So that's what he had given me the look, and I had got 3 patients now of POEM syndrome. Immediately I had transplanted these patients, and these patients are doing really very well. So Dr. Sudha Shetty, your question, please.
Okay, thank you, sir, for your sharing.
Yeah, thank you. Dr. Sudha Shetty, yeah.
Dr. Ria, excellent presentation. And it's a very simple question. If one patient has not received DARA as the induction or after transplant consolidation, but now he is not tolerating lenalidomide as maintenance, so can we use DARA as a maintenance?
That would depend on the, I think, risk profile of the patient. You can also give bortezomib as part of maintenance therapy in such patients. Bortezomib, in fact, is recommended if DARA, lenalidomide cannot be used. But if the patient was high risk to start with, or if the patient, I know in clinical practice we don't do MRD, but if your patient was MRD negative, the patient maybe even did not achieve a VGPR, then I think addition of DARA along with the DEXA would, it would be relevant in this subset of patients. Not in all, because bortezomib again can be used in some subsets of patients as maintenance.
Okay. Thank you very much. Thank you.
Thank you, Dr. Sudha Shetty. We have some couple of questions from the audience. Dr. Babita Shodi wants to know that whether myeloma can arise in a spectrum or it always happen de novo.
There are some countries where health checkup is very, very routine. So you end up picking up some clues that the patient could be having a pre-malignant condition. But in a country like India, mostly you don't see MGUS and smoldering. You directly have patients who come to you with a symptomatic multiple myeloma. But that said and done, we do have some patients with, a lot of patients actually with MGUS and smoldering that we are monitoring over the course of time. And I think like Dr. Someone just mentioned, all these other things, the TEMPI and the MGRS and the MNRS, the monoclonal gammopathy of neurological significance, all these things, they do sometimes evolve into frank myelomas over time. So you need not always have it as a spectrum. You can just have myeloma, or you may have something which is a precursor to a full-fledged myeloma. So that depends on the clinical context and the patient that we are dealing with.
Absolutely. Thank you. Another question from Dr. Krishnanathan Kannan. None of the clinical trials have shown OS benefit in that case. So why not Dara as second line, as it is a very expensive drug?
Yeah, that's an excellent question, actually. So what the trials have focused on is the PFS initially, and later on they moved on to stringent CR and MRD negative status. But what is again important to see here is the attrition rates and the diagram that I showed, the bar diagram, where the first chance is the best chance. So if you can get a good MRD negative status, if you can get a good stringent CR, you can keep the patient alive for the next 7 to 8 years. Progression-free survival there matters. And then the disease comes back and you give it. But if you don't use Dara there, you just use lenalidomide and Dexa or RVD alone, then your PFS is around 36 months. You get the disease back again, then you give the patient Dara. So I think rather than just entering that vicious cycle, you just treat the patient properly and well upfront, and then you see what happens with you. So here the OS data wouldn't really matter. And that is the reason why in the 2025 guidelines, Dara-based quadruplet has come up as the treatment of choice. So, but problem, like Sir rightly said, cost is a big problem in our country. So this, we can offer these patients to only patients who are affording or who are in some panel or some insurance patients. Not everyone would have access to it.
Thank you. Another question from Dr. Lee B. Sun. What antibiotic prophylaxis as well as antiviral prophylaxis would you like to offer on Dara?
Yes. So if the patient is the first cycle of Dara, I normally acyclovir is something that you should add acyclovir, because with Dara adding to your background of RBD, the risk of herpes increases by around 25%. So acyclovir should be continued for 6 months post completion of Dara. That is the first thing. And in most of my myelomas, especially upfront, if I'm using a quadruple Dara-based therapy, the first 1 month, I do give them some levofloxacin prophylaxis for the first 1 month, and then I don't give it beyond that. Cotrimoxazole, I don't give with Daratumumab.
Thank you. Another question from Dr. Raghvendra Rajesh Workar. Can you please give the detailed description of how IVIG is administered and how it is manufactured, how administered, and how do you manage the adverse effects due to IVIG?
So manufactured IVIG. IVIG is basically a protein. That is what I know from my MD days. It is the plasma is collected, it's purified, and immunoglobulin is synthesized. So rather than the manufacturing process, let's go to the administration process. So the dose of IVIG that is given in myeloma patients is 400 mg per kg. That is what you do. And indications, I would tell you, especially with these newer therapies, indications have increased. So till now, the indication was any myeloma patient who has any severe infection and the immunoglobulin levels are low. By low, I mean you look at the IgG levels. IgG levels should be less than 400 mg per deciliter. Anything less than that, your patient has a severe infection, IVIG has to be given as early as possible. Okay, that is the first thing. Now, with these newer therapies which have come up, be it Dara, and especially with CAR-T therapy and your bispecifics, IVIG becomes mandatory. Dara is known to cause hypogammaglobulinemia. Dara is known to cause immunoparesis. So, in this subset of patients who have recurrent infection and have IgG levels low, I give IVIG prophylaxis. I give it once every 3 weeks, the same dose, 400 mg per kg, till the immune reconstitution has occurred and the globulin levels are good, patient doesn't have any infections. Now with teclistamab, you need to give it regularly. CAR T, you need to give it only for the first cycle. Normally, we prefer to give it, and thereafter, as and when needed.
And how do you manage the adverse effects due to IVIG?
Adverse effects, normally it is more of allergic reactions and anaphylactic reactions rarely. So we always pre-medicate the patient with steroid, hydrocot normally, and antihistaminic with the paracetamol. The first IVIG vial, we give it very slow. We give it sometimes even over 2 to 3 hours. And the next vial onwards, you can give it over 60 to 90 minutes. Any reaction, you stop, give the patient hydrocot, Avil, that is enough. Anything beyond that, if it is anaphylaxis, then subcut adrenaline is what we do.
And for those patients who are already IgA deficient, would you like to screen them before giving IVIG?
See, as part of our protocol for IVIG, routinely we do not screen those patients because it is very, very rare. So till now, I've just seen one patient with IgA deficiency who presented to us, and we diagnosed this patient retrograde. But as far as myelomas is concerned, you already have your immunofixation report. You have the IgA levels. So you already have it with you before giving the IVIG.
And they are all acquired IgA deficient.
It is all acquired, yes.
So another question from Dr. Lee B. Sun. After how many cycles of DARA-based regimen during induction, you would plan for stem cell collection?
Yes. So normally we go for 3 to 4 months of a DARA-based injection therapy, 3 to 4 months, and then we plan for collection and transplant if the patient is willing at that point.
Exactly. So another question from Dr. Abhinit Deshmukh. How do you monitor for IgG kappa levels, myeloma on DARA?
Yes, that's a very good question because DARA itself is a IgG kappa monoclonal antibody. So what it does is it interferes with your estimation. So ideally, what should be done is you need a immunoflex reflex assay. But what it does is it uses a monoclonal antibody which captures the DARA. The DARA goes to one point and your M band goes to another point. But unfortunately, in routine practice, we don't have it. Research settings, like currently I'm doing 2 trials on myeloma, so they do it as part of the research protocol. They do it. They do these capture assays. Another method of bypassing this is something called mass spectrometry, which is again done in research settings. It is not routinely available to us. So these are the 2 ways you can avoid it.
Another question from the same note. The DARA interferes with blood grouping and cross matching. So what all precautions would you like to take?
Yes, DARA does interfere with blood group cross matching. What it does, it goes and coats the CD38 molecule receptor is also present in RBCs. So it goes and binds to that. So it becomes difficult to estimate the minor antigens which are present. So before starting DARA, what we do is we do a blood group and we also do a extended alloimmunization panel. So we do a extended antigen matching and a blood group. So we have our baseline and then accordingly we transfuse the patients.
Thank you. Another question. Yes.
To extend the question with the DARA versus M band by detecting through mass spectrometry, does the DARA has different functionality or structure compared to the regular IG kappa, something like that? How
Yes,
can
it
we
does.
differentiate?
It does. So mass spectrometry is based on the relative size of the molecule. I had presented a lecture on this. So basically the M band and diagnosis that is taken, it is quantified. It has a very different profile than this particular molecule. And on mass spectrometry, depending on the mass of the molecule diffuses in the medium in a different way at a different point, and that is how they differentiate between the two. It's a very complicated thing, but the basic size of the molecule and the structure is different. That is how you can differentiate between the two.
Oh, okay, thank you.
Thank you. Another question from Dr. Raghavendra Rajesh Varkar. If quadruple therapy is given every 28 days and continued for years without stopping after 2 years, and MRD is monitored, what will be the life-threatening complications and how do you manage them? And this happens very well in high-risk myeloma patients who are not eligible for stem cell transplant. Your comment.
Giving this sounds like a real very exciting thing to do, but it will not be practical because giving a quadruple therapy lifelong for a patient will be associated with a lot of side effects, including infections. We know that these drugs also increase your tendency towards blood cancers. So, and there is obviously no trial that has studied this. So I wouldn't recommending doing it lifelong. You do it for a finite point and then you de-escalate your therapy. Either a single drug or preferably a double drug. In a high risk, I would go for a double and sometimes even a triple drug, but the third drug being a low dose steroid rather than one of these immunomodulatory agents, because the side effects would be very difficult to manage if you give it life.
Exactly. Dr. Sudha Shetty, you had another question? Right. So I think there are no more questions. I would like to ask you, Dr. Ria, if you get a patient today in 2025, financially not a big burden, if a patient is standard risk myeloma, what would you start with in this patient? Transplant eligible, transplant not eligible?
Both the patients, I would start DARA RBD. Transplant eligible and transplant ineligible, both. Transplant eligible, I will continue DARA RBD for 3 to 4 cycles. I would transplant the patient. Post-transplant, I would put the patient on, if it's feasible, 2 cycles of consolidation with DARA RBD. And then I would do maintenance therapy. Standard risk cytogenetics, it could be LEN, or if the patient is willing, it could be DARA. I would prefer LEN with standard risk cytogenetics. If the patient is not transplant eligible, I would do DARA RBD for 8 to 10 cycles and continue the patient on either LEN alone or preferably DARA with LEN, because I'm not transplanting this patient.
Perfect. And this you'll continue your maintenance for how long?
If I've done a transplant, then it would be 2 years. If I'm not done a transplant, ideally it should be lifelong, but practically it is not possible to convince a patient to take something lifelong. So 2 to 3 years again in transplant ineligible patients is what I would do.
Perfect. And second question, have you started doing MRD monitoring in patients of myeloma in your
Yes.
practice?
Yes. In our transplants, especially in patients in whom we are transplanting, we are doing it. We are doing it before transplant. To see if the MRD is negative or no. And we are doing it at the start of maintenance therapy. 2 time points is when I'm doing MRD. I'm not honestly incorporating those results in my practice. I'm not using MRD to guide my therapy, but I am doing it.
And this is which method?
Flow cytometry.
And the sensitivity is 10 to -5.
-5, yes.
Perfect. So any other discussion want to ask, any other question? Well, so there are no more questions from the chat box and no more hand raise signs. Dr. Ria, fantastic lecture, wonderful discussion, what a flow, and every topic, subtopics were very well covered. Fantastic. Thank you so much.
Thank you so much, Dr. Khurram. Thank you.
Thanks a lot.
Thank you. Bye-bye. Thank you.
Thank you, ma'am. That was wonderful.
Thank you so much. Thank you. Thank you. Bye.